few seconds behind this morning, but wonderful to see everyone for Neurology Morning Report. It's Tuesday. So we have a case from Kirtan, which I'm very excited about, and many are very excited about, have written to me. Kirtan has a case this week, so that is fantastic. And we will just need two discussants to discuss Kirtan's case with him and with myself. Ideally, one identifying as a woman and one identifying as a man. Can we have two discussants who would like to discuss? Two discussants who would like to discuss a neurology case this morning. If you're thinking, well, I have neurophobia, I'm afraid to discuss a neurology case, that's a perfect reason to discuss a neurology case because your neurophobia will be reduced. Or maybe you're thinking, English isn't my first language, I'm not 100% sure. We have Spanish speakers, Portuguese speakers, French speakers, Hindi, Urdu speakers, other speakers. So Marco, fantastic. It's been a long time. And who would like to discuss with Marco? Ideally, someone identifying as a woman. Who would like to discuss with Marco? Yeah, Kirtan, we know you would love to discuss, but you will be discussing otherwise. Who would like to discuss with Kirtan, with Marco, and with myself? Ideally, someone identifying as a woman. Please join us. Please join us. People are already guessing the diagnosis. Let's get some information first. Who would like to join Marco? Ideally, someone identifying as a woman. Valeria, we'd be happy to have you discuss. You're a frequent discussant, which is phenomenal. In case anyone else who has not discussed before would like to join, going once, going twice. All right, take inspiration from Valeria and Marco for their courage to discuss this morning a case from Kirtan, which we know is going to make us think. And hopefully you will want to discuss next time when you see how much fun we are about to have. So Valeria, Kirtan, Marco, do you want to just briefly introduce yourselves and where you're joining us from, and then we will get started.
Yes, hello everyone, I'm Valeria. I am from Peru and I am really excited to discuss today. I know Kirtan cases are always, well, great, and he's a really exceptional person, and I know it's going to be a challenge, but hopefully I'm going to learn a lot.
I'm having the same feeling. Kirtan, Marco.
Hi everyone. I'm Marco. I've already been on CPS, but it's been a while. I've just finished my. I'm from Peru, and I've just finished my surgery rotation, so I'm coming back to some medicine. Very excited to come back to problem solving.
Fantastic. We will not be cutting anything this morning for sure. And Kirtan? You've been a frequent participant in Neurology Morning Report. Sounds like other morning reports, but just in case anyone hasn't met you, tell us what stage of your training you're at and where you're from, and then we will get on with the show.
Yeah, so good morning. I'm a final year medical student from Csf Medical College, Ahmedabad. So it is situated in the state of Gujarat, which is in the western part of India. And I am so excited to be here, present my first case. And I would like to thank you, Travis, Gabby, and all the team for giving me this opportunity to present a case. And it's my first time, so please bear with me if I make some errors, and hopefully it will go well.
Well, no, we are thanking you for all the time and effort I'm sure you've put into this case. And there's a lot of buzz around it in the chat already. And as I said, several people emailed me, get excited because Kirtan has a case for you. So if you wouldn't mind, Kirtan, just telling us in as few words as possible the presenting concern, presenting complaint, and then Valeria, Marco, and myself will begin discussing. Just the chief concern, please.
Yeah, so the chief concern was behavioral changes.
Behavioral changes. Okay. Valeria, where would you like to start?
Yeah, so I mean, that is a very broad symptom. I would like to know exactly what that means. That could be either an altered mental status, and in which case I always remember the mnemonic mist that I learned from you, and thinking about metabolic causes, toxins, structural causes, and infections always. But then also going back to the thing that you always say, Aaron, is, time onset and location. So kind of knowing exactly the time onset of these behavioral changes is going to be very important to also have a smaller differential diagnosis, and maybe also knowing exactly what that means in case there's maybe some kind of frontal liberating syndromes, something like that, that could be going on too. And so, yeah, that's kind of what I'm at.
Fantastic. Yes, I will not take any credit for the missed mnemonic. I think that comes from Robbie and Reza, though it's a nice one. As you know, my sort of mnemonic device is hinged on localization and time course, which you alluded to. The localization, as you said, I mean, we're in the brain here, right? We could have medical causes of altered mental status, as you alluded to, but it's Neurology Morning Report. Probably it will be a neurologic etiology. And if we're thinking about lesions that could cause behavioral changes, we're somewhere in the brain, and very likely to be involving the frontal lobes, as you said, which are sort of responsible for personality and decision-making behavior, those sorts of higher level cognitive functions. And then you said the time course will be, of course, very important here, because if these behavioral changes were sudden versus onset and evolution over years, we'd have very different differential diagnoses. So since you started there, Valeria, and that's excellent, you mentioned using time course. Do you want to fill in sort of, I like to break time course into hyperacute, acute, subacute, and chronic. So I split acute into truly sudden, instant onset, and then acute, which is fast, but not instant. So over hours to days, and then chronic, the sort of months to years, and then subacute, somewhere in the middle, weeks, months. Do you want to fill in any of those for behavioral changes? Well, this applies to any neurologic symptom, right? But you can use that in general or for behavioral symptoms specifically. When we get the time course, do you want to fill in any of these, or any thoughts on how you would use the time course piece to help us here?
Yes, so I think when it is hyperacute, always think something vascular or something traumatic, maybe. I mean, the classic case is that patient that had an injury and developed changes in his personality. Then maybe thinking metabolic causes on something more acute, and other possibilities of infectious diseases that are not so like fungi or tuberculosis, that could also manifest, for example, as a mass in the frontal lobe, and could also lead to some behavioral changes. I'm also thinking, I don't know if it's possible seizures to manifest like this as behavioral changes, but that I will expect maybe a more, or well, and then maybe something degenerative or autoimmune as a more progressive subacute chronic case, and well, of course, infectious etiologies such as mycobacteria, parasites, and fungi that could also affect the central nervous system.
Fantastic, amazing discussion, both in terms of the general categories and how we'd apply them to a potential brain or maybe even frontal lobe process, right? So for any neurology, and I realized later after I learned this in neurology, it applies in general to medicine as well. Instant, right? We're thinking of vascular things. So in the brain, things like stroke, ischemic stroke, hemorrhage, subarachnoid hemorrhage from aneurysm rupture, sudden onset, right? Trauma, usually obvious from the history, though not always. If someone is just found confused, did they have a head strike of some sort? And then seizure, as you said, a lot of patients, the seizure is very short and they're found in their postictal state. And so the behavioral change or confusion could be a postictal state, or some seizures cause behavioral arrest or behavioral changes, or if a patient is in non-convulsive status, going from seizure to postictal state, seizure, postictal state, the so-called, it's called in literature sometimes wandering confused phenotype of non-convulsive status epilepticus, as opposed to coma. It can even be that extreme. And then toxic metabolic really applies across all the time courses, right? So you could have acute hyperglycemia or hypoglycemia. You could have acute renal failure, but you could have chronic renal failure. You could have acute hepatic failure. You could have chronic hepatic failure. You could have drugs or medications that from the first dose cause an altered mental status, or ones where that comes on over days, weeks, months. So toxic metabolic always in there. But hyperacute, so we put toxic metabolic across all of them, but hyperacute, really vascular trauma, seizure, migraine, you can get a confusional aura sometimes with migraine. That's pretty uncommon. And then acute, the two main categories there, again, toxic metabolic is everywhere, infectious and inflammatory, the ones I would think of. And particularly, I think you mentioned this, if it's acute, so emerging, evolving over hours, days, we're thinking more of bacterial or viral infections, right? Like bacterial meningitis, viral encephalitis, bacterial brain abscess, epidural abscess, et cetera. And that being said, you mentioned fungal, tubercular, and parasitic infections tend to be more subacute chronic, although there are exceptions in all categories, right? And then inflammatory in neurology often, although not always, means demyelinating. So demyelinating lesion or lesions could present acutely with altered mental status, like the pediatric syndrome ADEM, acute disseminated encephalomyelitis, sort of a fulminant demyelinating syndrome, usually post-infectious in children, some of whom will go on to develop multiple sclerosis or a newly identified syndrome called Anti-Nmda syndrome, but can just present with an isolated picture. And Guillain-Barré, right? The sort of quintessential inflammatory neurologic disease, symptoms evolve over hours, days. And then subacute, we have some infections, some inflammatory conditions like antibody-mediated conditions, perineoplastic conditions, CIDP, the chronic cousin of Guillain-Barré, chronic immune demyelinating polyradiculoneuropathy, as opposed to acute inflammatory demyelinating polyradiculoneuropathy. And then chronic, and also in subacute, I would put neoplasia, right? So if you had a malignant brain tumor or metastatic tumor to the brain, those deficits tend to evolve in that sort of subacute time course, unless they cause a seizure or a hemorrhage, something like that, where they present more suddenly. And then chronic, maybe benign neoplasms could sort of bleed over into that category, degenerative conditions, and then always toxic metabolic. So it sort of applies to everything. We've sort of found some ways we could get behavioral changes that way, but I'm sure there's even more we can discuss. Marco, what thoughts do you have about this chief concern? And then I'll add a few more things to Valeria's excellent beginning here, and we'll hear some more of the case.
I think it's very interesting. Thank you very much for that explanation. So I believe that something we could do to localize it a bit more could be, because you focused on the time period. I think I can focus a bit on the localization part. So we know that this is affecting the brain, and it could be diffusely affecting it, or it could be located in a certain part. If you think of it as a diffuse affectation, you could see it as an altered mental status and apply the missed mnemonic there. And if you go to a more localized effect, that meaning that it affects just one function of the higher functions. For example, if the behavioral changes are due to a language alteration, or to lack of impulse control, or to decision-making, modification decision-making, then you could classify it either as cortical or subcortical. And then you could go from there to see specifically which higher function is affected, and also if there are associated symptoms, especially related to dyskinesias. So with that, we could get a list of differentials with, I believe, primarily with the degenerative diseases. Like if it's cortical, you could think of Alzheimer's, and if you have a lack of impulse control, like they have mentioned, you could have frontotemporal dementia, or you could have fixed dementia as well. So I think that could help us a lot if we could have specifically which type of what is the cause behind the behavioral changes. If it's what is the higher function that it's affected of, or if it's all of them that are affected.
Fantastic, brilliant discussion, Marco and Valeria. So Kirtan said behavioral changes rather than altered mental status, right? And we'll have to see what that actually means in the history. We always like to dig deep here, as you know, and I like to spend a lot of time on the chief complaint, because once we've laid out our framework for approaching this chief concern, some of our differential diagnoses, right, then the history is allowing us to really sort of zoom in. Once we hear that time course, you know, our sort of list of things gets smaller, but the dives go deeper right into what those could be based on the details. So you're right. If we're thinking about altered mental status or cognitive changes, and even to some extent, as you said, very astutely, behavioral changes, right? Why is the behavior changed, right? Is this a primary change in the patient's personality? And then we would really think of that probably associated with frontal lobe dysfunction, though not all of these perfectly localize. But what if the behavioral changes are due to frustration from a cognitive deficit, right? And the personality changes are secondary, and what could that cognitive deficit be? What if the patient is having a language disorder, Broca's type aphasia, like the case we discussed last week, right? And it's not a full aphasia, global aphasia, or a full Broca's aphasia leading to muteness. The patient's just having a lot of frustration finding their words, and that frustration is leading to behavioral change, but the primary problem is a speech problem. Or what if they have a memory problem, right? And because their memory is not adequate, and they're maybe trying to compensate for that or cover up for it, and struggling in daily life, then there is a secondary behavioral change due to cognitive dysfunction, right? And we know it's Neurology Morning Report. Kirtan is going to have some neurologic diagnosis for us probably, but this is where the boundaries between neurology and psychiatry blur, right? Freud was a neurologist, if I'm not mistaken, right? And at one time, this was the same organ, the brain and the mind. It's still the same organ, but things have sort of diverged in terms of those fields, but there are many conditions that sort of bring them back together. One, as you mentioned, Marco, the neurodegenerative dementias, right? Patients with frontotemporal dementia that really affects personality and behavior, although that can be affected in Alzheimer's disease as well. And there are psychiatric comorbidities to many neurologic disorders, Parkinson's disease, epilepsy, et cetera. So we would have to consider primary psychiatric etiologies. We would have to consider neurologic etiologies with psychiatric manifestations. And then, as you said, what if there's just some diffuse process, either medical, systemic process, metabolic process affecting the brain that's led to neuropsychiatric symptoms without a neuropsychiatric disease at the root? So I think those are important points as well as we characterize this. Does the patient have cognitive deficits, or is this purely psychiatric, neuropsychiatric symptoms? And if it's the latter, is it of a neurologic etiology, psychiatric etiology, or medical etiology? And then what's the time course? So lots to say about those two words, behavioral changes. But if we take it at face value, and it's truly behavioral is sort of the main presenting feature here rather than cognitive, although we may hear about cognitive, that puts us a little more to the frontal lobes, presuming it's primary neurologic. And we're really going to want to know that time course, because if this is a subacute to chronic process, we'll be wondering if there is some type of frontal lobe mass or inflammatory process or degenerative process like frontotemporal dementia, as was alluded to. Faster, we could think about Creutzfeldt-Jakob disease. Prion disease can present in many ways, but one would be behavioral. So we're really going to be keyed into what are those behavioral changes, right? Are they accompanied by any cognitive changes? Are there any other features here that well, the time course, of course, and then other features that sort of point us in a particular syndromic or etiologic differential diagnosis. Okay, Kirtan, we'll see how we did. Tell us about the HPI, and then I leave it at your discretion whether in this aliquot you want to fill in the past medical, med, social, family, or whether you'd like us to discuss the HPI first, blinded to that information, and then take it into account in the next stage.
So amazing discussion so far. I have already learned so much from you guys. And yeah, maybe I can give you past medical history and bit of meds along with the social history all the way up to the physical examination. So yeah. So the HPI stands like this. So we have a 16-year-old girl who presented with difficulty in voiding urine, constipation, and back pain since 2 weeks. It's a little bit of a long aliquot, so I will try to pace myself. So actually it's since 2 weeks.
So 2 weeks of difficulty with yeah.
So difficulty in voiding urine, constipation, back pain since 2 weeks. Apart from that, we have subacute onset of irrelevant talking anger, irritability, confusion, temper tantrums, disorientation, and incoherent speech.
Subacute, you
Temper
mean
tantrums?
weeks,
Yeah.
months, or sorry, weeks, months, or?
So sort of during the last weeks, so the top complaints, that is the voiding urine, constipation, all those were present since 2 weeks. And these episodes of irritability and all this have started since last 1 week. So confusion, irrelevant talking, anger, irritability, temper tantrums.
It's okay. You can keep going, Kirtan, and we'll
Okay.
I think our scribes will
Okay.
catch up to you.
Sure. Okay, sure. And she denied having fever, chills, cough, arthralgias, myalgias, rashes, any headaches, weight loss, dizziness, visual blurring, double vision or hearing loss. So all these were negative complaints. So I will repeat once more. She denied having fever, chills, cough, arthralgias, myalgias, headache, weight loss, dizziness, visual blurring, double vision or hearing loss. Okay, so now moving on to the next part. So she had a episode of left-sided arm and leg weakness 6 months back. She had an episode of left-sided arm and leg weakness 6 months back. MRI at that time revealed the hyperintensity on T2 Wade flare sequences of the right thalamocapsular region and the entire cervical spinal cord, medulla, and pons extending caudally up to the T1 segment without any significant enhancement of the lesions. At that time, it was presumed that it was most likely a case of ADEM. So she subsequently was treated with steroids and plasma exchange, and she showed remarkable improvement after being treated with plasma exchange and steroids. Do you want to repeat that, Aaron?
Nope. No, I think we're good. Thank you.
All right.
And so she recovered completely from that, Kirtan? Oh, sorry, you're muted, sir.
Yeah, sorry. So until this episode, so until the 2 weeks back, she was completely fine.
Got it. Okay, great. Anything else you want to give us history-wise?
Yeah, just a sec. So regarding past medical history, none besides the questionable episode of ADEM. Medications, none. Family history also not significant. Social history, she denies alcohol, tobacco, or illicit drug use. And allergies, none allergies. So yeah, that's the end of aliquot number 2.
Wow. Okay. You're up first, Marco. You can take any piece or every piece or any piece. And Valeria and I will sit back and listen to you while we think about what we want to say.
Yeah, this is a lot to take in, different from what I expected, to be honest. So just to start and go with what we were thinking, this would kind of take us more to the diffuse localization or frontal, but not specific to one type of cognitive dysfunction. So that's out of the window. So we can focus more on our mnemonic, and if you have subacute changes, then that would lead us to infectious or inflammatory causes. Given the past medical history, where we have a case that's either inflammatory or demyelinating, then you would think that this is the same etiology, right? So if it was an episode of transverse myelitis or an episode of a flare of multiple sclerosis, then you could argue that this is a similar episode in the last case, but I don't know how that could fit with transverse myelitis. But I'm still a bit puzzled of on how to localize these symptoms. So I guess you could think that this altered mental status combined with the affections in voiding urine and constipation could localize frontally, but then you could also have two lesions, one in the spinal cord and one in or multiple in the brain, causing this. But I am very puzzled with this. Still, I believe that you could argue that this is just another episode, another flare of whatever the demyelinating cause of the first episode was, either MS or another syndrome or another etiology. Yeah, I think that's what I can get right now.
I'm muted, sorry. Fantastic. I think you're asking the right questions, right? Until we heard that past medical history, right? We heard behavioral changes, and then we heard this presentation of back pain, constipation, voiding. Sure sounds like a spinal process of some sort, not knowing yet, is it extradural, intradural, extramedullary, or intramedullary, a framework we've talked about before, but something going on in the lower spine. And if we don't hear about any weakness of the legs, wondering if this is some type of compression of the conus or sort of very distal sacral cord, right, to give us just sort of the S2 through 4 issues with the sphincter dysfunction, and not affect sort of the cauda equina or motor or sensory pathways in the lumbar region of the cord. But then that back pain should have little to do with something upstairs in the brain causing behavioral changes, right? So you pose the very interesting question, right? If we didn't have that back pain, could we explain all of this with a frontal lesion, right? Obviously this woman is very young. She does not have normal pressure hydrocephalus, but that's an example of a condition where there is frontal lobe dysfunction that causes cognitive changes, but also causes urinary incontinence or other urinary issues, right? From affecting frontal pathways. And so I think if it were not for that back pain, right, we could maybe try to put this all together in one lesion, as you very astutely said, and say maybe the sphincter dysfunction is from frontal control, because, right, we all are born without a sphincter control, right, and we learn it, right, and so that comes from using the brain, right? But then we hear this past medical history of this presumed inflammatory syndrome, though we don't have the records per se, we don't have the imaging from that time, diagnosed as ADEM, something I had mentioned earlier, acute disseminated encephalomyelitis. I think of this as like the central nervous system cousin of Guillain-Barré. It's an acute demyelinating inflammatory syndrome of the brain and spinal cord, central nervous system, as opposed to the acute inflammatory syndrome of Guillain-Barré, which is of the peripheral nervous system, usually demyelinating, but can be axonal. It can be post-infectious, post-vaccine, as I mentioned, can be self-limited, can be the first presentation of multiple sclerosis, can be the first presentation of what we now have recently described, we broadly, not me personally, we in neurology, as Anti-Nmda syndrome, which is sort of one of the newly described demyelinating syndromes, which can present with the ADEM phenotype. So if we're going to link these, right, you're asking the question now, did she have this ADEM? And now we have to treat everything as somehow related to that. So she had some prior demyelinating type of syndrome. Does she now have a new demyelinating lesion or multiple demyelinating lesions causing the confusion, or some in the spine, spinal cord, right? Although it would have to be very low to avoid weakness and sensory change and only affect the sphincters. Or is this a completely new presentation? And some children have ADEM, and she had ADEM, and now we have to treat this as a new presentation unrelated. I think that's going to be one of the key questions we're going to have to figure out, right? Was ADEM the first presentation of her current disease? Another question I always ask with demyelinating conditions is that even the correct diagnosis, right? I've seen many patients carry a diagnosis of multiple sclerosis. They've been misdiagnosed. The clinical picture doesn't fit, the imaging doesn't fit. And then whatever it was before is the new presentation, a new presentation of the same underlying disease or a separate presentation. I think you're asking the right questions, and I don't think we know the answers yet. Presumably that initial episode, if it resolved with all of those treatments, was probably inflammatory and was probably not infectious, right? Or it would have gotten much worse with all of those treatments. And presumably a young person of this age getting an inflammatory syndrome, we would certainly think about demyelinating disease, but other things on the differential. How are you thinking about this, Valeria?
Yes, I'm very puzzled, but I think when I heard the HPI first, I was shocked a little bit with the time onset because it was quite fast. I think at first, honestly, I thought, okay, this could be metabolic and could cause maybe like irritability and confusion. I remember like adrenal insufficiency could cause constipation and back pain, and could also cause some confusion. I don't know if this level of change in behavior, but it was like the first thing that I thought. Then when he referred also, and also I thought about something obviously spinal, and with the past medical history of ADEM, that the fact that it is kind of post-infectious of post-vaccine, I also thought about transverse myelitis as a possibility, like two different etiologies happening. And also, well, autoimmune, that could also be behind both presentations, and I mean, a favorite of Kirtan. But honestly, I'm not sure. I mean, I think at first I thought metabolic, then I thought spine, and then I thought, okay, this seems more located to the brain. And I think both are kind of linked through something inflammatory, like post-infectious, post-vaccine, or autoimmune, or MS, I think could also be a cause of transverse myelitis. So I don't know if this could be the case of that.
Yeah, great thoughts. Let's talk a little bit about transverse myelitis, right? So it's really a syndrome rather than a disease per se. And then the terminology is in some ways falling a little out of favor. Jack and I put together, Jack put together, I will say, a beautiful schema of transverse myelitis. And I looked at it and we made some changes together. And when we posted it on Twitter, there were some neurologists that said, oh, that term, is falling out of favor. It's not useful anymore, these sorts of things. Why are people saying that? Well, transverse myelitis is the spine, right? Myelopathy is the spinal cord. Myelitis, inflammation of the spinal cord, right? Not to be confused with myopathy of the muscle. So, and transverse suggests a lesion that's affecting the entire axial diameter of the spine. So below that, you would have weakness, bowel bladder dysfunction, sensory loss, full transverse lesion of the spinal cord, as opposed to anterior cord syndrome, posterior cord syndrome, subacute combined degeneration, things we've touched on in other sessions. But some people have pointed out, well, not all transverse myelitis is inflammatory. So the traditional description is this is an inflammatory condition, post-infectious, post-vaccine, or the first presentation of a demyelinating disease such as multiple sclerosis or Devick's disease, also called neuromyelitis optica. But you can get that same syndromic presentation of a full thickness axial spinal cord lesion from an infection, from a structural etiology, from an infarction, that could be fully transverse. And most of the myelitis that occurs in multiple sclerosis is not fully transverse. Just like those little lesions around the corpus callosum and the subcortical white matter in the brain, you tend to get radially oriented small spinal cord lesions in multiple sclerosis in the spinal cord, as opposed to something truly transverse. So we can still use that term, it's still a useful term, but we have to remember it's a syndrome, not a disease. And not all myelitis is transverse, and not all transverse myelitis is just a immune-mediated condition. So what can we say about this initial case? The presentation of left side arm and leg weakness could be a right-sided brain lesion or a left-sided cord lesion, but Kirtan described, or at least it was described to him, we don't know yet if he's seen the imaging himself, but a lesion extending all the way from the cervical spinal cord all the way to the T1 segment. So, and through the brainstem even. So from the brainstem to the thoracic cord, if I understood correctly. So if you see what we would call a longitudinally extensive transverse myelitis or longitudinally extensive cord lesion, does that help you at all in terms of considering possible etiologies? So we consider a lesion of the spinal cord to be longitudinally extensive when it spans over 3 levels. So, C5 through C7 would be, 5, 6, 7, 3 levels. So if this lesion is truly brainstem to T1, right? That's 7 cervical levels, the brainstem, and then the first thoracic level, that would be called longitudinally extensive, and that has a particular differential diagnosis. Any thoughts on that, Valeria or Marco? What would be signified by that? If we understood correctly, first presentation of a longitudinally extensive transverse myelitis.
Yes, I think I remember it from the schema that Jack posted, I believe. I mean, I think them was also that. I mean, that's the presentation that can stretch to a lot of segments, but also I remember vasculitis like Beset's also had that presentation, and some things that are more common, for example, in Brazil, sarcoidosis, I think. And I am not sure if post-infectious and post-vaccine could also present like this, but yeah, that's kind of what I remember.
Yeah, it has a broad differential. All of what you said was true and is on that differential. There's probably one condition that most people, I shouldn't say most people, that most neurologists would think of first if you said a longitudinally extensive transverse myelitis. Marco, can you guess what I'm thinking? I'm not asking a great question pedagogically, but.
If I am not mistaken, Nmo presents with a longitudinal extension.
Correct. So neuromyelitis optica, or NMO, also called Devick's disease, the N for neuro, the M for myelitis, and the O for optica. The originally described cases had optic neuritis and transverse myelitis, with that myelitis extending over multiple levels, often not just 3+, but many. And this was thought to be sort of a variant of MS, but they found a biomarker for this disease. We still don't really have a serological biomarker for MS. We have imaging biomarkers with antibodies against that aquaporin 4 receptor. And so once a biomarker was developed, we saw that this syndrome doesn't always have M and it doesn't always have O, as one of my colleagues like to say. So if you saw very severe optic neuritis, often bilateral or one and then the other, as opposed to the more mild unilateral, often optic neuritis in MS, and or a very extensive, very fulminant transverse myelitis, that would lead to concern for this condition, NMO. But it can have other presentations. One of the classic presentations once people have this biomarker is the area postrema syndrome, where patients present with intractable hiccups, coughing, nausea, and vomiting from lesions around the fourth ventricle where the area postrema is. And I think there's just a lot of aquaporin 4 receptors around the ventricle. So this has very particular patterns of neurological involvement, radiologic involvement, not just limited to the M and the O of NMO. So that picture would make you think of NMO, but Valeria, you're absolutely right that there's a long differential for this. Many of the other inflammatory myelitis, you mentioned sarcoid, the classic involvement of the spinal cord in sarcoid is actually involvement of the pia, the arachnoid, but you can get a myelitis as well. If we take the itis out and just say longitudinally extensive, right? B12 deficiency, usually you see the dorsal columns lighting up the whole length of the cord. We've had several dural AV fistulas in this morning report, right? Those often cause signal change throughout the cord. Radiation-induced myelopathy can cause signal change throughout the whole cord. So inflammatory is sort of the top of the list. Infections, I should mention, mycoplasma, sort of para-post-infectious myelitis is often longitudinally extensive, but we're pretty sure this patient didn't have an infection 6 months ago and get immunomodulatory therapy and then get better. So could she have had a first presentation of neuromyelitis optica and now has some new lesions in the brain causing these changes, maybe new lesions in the cord? Or what we can see also in patients with prior demyelinating disease or prior stroke, really any prior neurologic insult, is a phenomenon called recrudescence, in which the patient has a prior lesion and some systemic insult causes the deficits to recrudesce or reemerge. So for example, a patient's had an MCA stroke in the past, say a left MCA stroke, and has had some mild aphasia, recovers, and then that patient gets a urinary tract infection or pneumonia, and looks like they're having the stroke again. They come to the hospital, people say it's a stroke, and you think statistically, would the patient have the same exact stroke in the same exact place? Probably not, though can happen. And the patient recovers with treatment of the medical illness or removal of the offending medication. So could this patient have a syndrome that has a pre-existing lesion that has decompensated in the setting of a systemic process? Without the fever, cough, chills, it's hard to invoke an infectious etiology. We haven't heard about medication drugs, although we don't always hear about those. Could that have caused this syndrome? Always on the differential for behavioral changes. But I think agreeing with both of you, this first presentation sounded demyelinating if we take it at face value. And so we're really pushed to think how many things could happen to this 16-year-old woman in such a short period. Presumably, she has another demyelinating episode. And so what condition would that be? I think we lost the whiteboard, whoever is sharing it. Did someone lose their connection or? Here we go, we're back. So Valeria and Marco, we're about to hear the physical exam, and I'm not sure this is going to get us closer to the diagnosis beyond what we've already been wrestling with, though maybe we'll see a clue that will take us in a different direction. Is there anything in particular you are looking for here that might help us with this? Some of the things we're considering, we're mostly sort of in an inflammatory demyelinating category, both because of the person's young age, lack of infectious features, and very much because of that prior presentation. Otherwise, I think we'd have maybe a broader differential, but we'd still be thinking this is a young, otherwise healthy individual with a new neurologic deficit in a sort of acute to subacute pattern would make us probably think about demyelinating disease. Otherwise, like one of the cases Maria presented many months ago, that was a recent podcast of a young man with demyelinating disease. Anything in particular, Marco or Valeria, your antenna is up for in this exam before Kirtan tells us a little bit about it?
Yes, I think I would probably be more interested in maybe lower extremities and see if there is any signs of motor dysfunction or sensory levels, just because of the possibility that it could be spinal. And yeah, well, mental status. I mean, we already know that the patient is confused and with all these behavioral changes. So to see the extent of that, and yeah, that's kind of where I'm at.
I think that's great, right? We want to try to assess what where this problem is in the spine and how much of it is old versus new. That might be a bit tricky. We want to characterize this altered mental status. And when you said we really know most of it from the history, I looked over at the history and I saw that Kirtan said that it was episodes of irrelevant talking, anger, irritability. Kirtan, was the patient normal cognitively and behaviorally between these episodes, or this was just sort of continuous and progressive worsening of her mental status?
Yeah, so she actually never returned to her baseline, but she was definitely better in between the episodes.
I see. So that's an important detail, right? And so why, any sense of why I might ask that, Marco or Valeria? Why would I be interested in whether these are episodes, meaning she's continuously not herself, but with periods of being worse, or whether she has periods of being altered and then is back to normal? Why would I ask something like that? Or what do you think I'm fishing for here or looking for? Any thoughts?
Honestly, when I hear episodic, I think seizures. So
yeah,
yep. I thought about that.
Yeah, that's what I was wondering. When you hear episodes, episodes of something coming from the brain, you have to wonder about seizure, especially if the patient's returning to normal. So why would she be having seizures, right? If we took that HPI at face value, our differential is enormous at this point. If we keep that other event there, you can seize from any prior lesion, right? Epilepsy is not always something you're born with. In fact, very commonly it's due to structural lesions, a prior stroke, a prior head injury, a tumor, a prior brain surgery. If the only lesion there was a thalamo-capsular lesion, in principle, you shouldn't seize from that. It's usually cortical lesions from which you would seize, but maybe there were other lesions there we just didn't hear about yet. So it's a very complicated picture, isn't it? So one thing I think we'll be interested in mental status-wise is whether we can observe a true fluctuation here, not just sort of a delirium fluctuation in the sense that there's general alteration with fluctuations in level of attention and arousal, but is a patient normal and then has a sort of very stereotyped episode of behavioral change that would make us think about whether those could be some type of ictal seizure phenomenon. All right, Kirtan, what did you find on the exam? We expected you to stump us and you have not disappointed us. What happened on the exam? And then we'll pause there and see what we want to think about in terms of tests we would want to order to try to sort this out.
So actually you have got almost everything. So kudos for the discussion.
One more thing, sorry, Kirtan. The other thing I would want to look at in this patient is her eyes. Why am I interested in her eyes? Valeria, you guessed what I was thinking last time. Marco, you want to guess what I do this ask a question, ask you why I think I'm asking, because when I've watched master clinicians and learn from them, I see the questions they're asking. I'm always wondering, I wonder why they asked that. And I used to go up to my professors after I attended and said, why did you ask them this? They say, oh, because I was thinking about this. So I'm trying to emulate that here. So why am I curious about the patient's eyes?
Yeah, I'm not completely sure. I would guess it may have to do with extraocular movements to see if there is affectation of the cranial nerves. But it could also be to see if there's any structural lesion in the eyes that maybe could point to another toxin cause, maybe. I am 100% sure.
No problem. Yeah, so we definitely are going to want to do a complete neurologic exam, look for any clues that are going to help us here. Particularly though, I'd be looking for eye findings that might help us in this overall context of the possibility of demyelinating disease. So the patient, we'd want to ask her if she ever had visual loss. Kirtan told us no, but some patients either may not remember or may have had a mild episode of optic neuritis. And then we could look for a relative afferent pupillary defect, right? The so-called Marcus gun phenomenon, where you shine the light in one eye, right, and the pupils constrict, and you move the flashlight to the other side, and it looks like it's dilating to the light. It's not dilating, right, to the light. It just isn't seeing the light. And sometimes you'll see that very subtle difference when you swing the flashlight back and forth. That can tell you maybe there was an optic neuritis or optic neuropathy in the past, which could sort of maybe help us down this pathway of demyelinating disease. The other thing is, people have stumped me with a few recent cases of very atypical presentations of syphilis. I'm not sure I can relate this case to syphilis if there's all these lesions in the cord and we don't have any classic presentations, but you will soon hear a podcast in which I was fooled by the great imitator by one of your colleagues. And so I just want to look for light near dissociation as another clue to make sure I'm not missing another stumping case of syphilis presenting in a completely atypical way, though that was not on my differential here. Though I will say quickly, case presented to me in Malawi when I was there as a woman with acute onset paraplegia, and everyone kept looking at the spine. She had urinary incontinence paraplegia, and she kept becoming more and more altered. And finally, they scanned her brain, and she had bilateral ACA infarcts, to Marco's earlier point, causing the paraparesis, urinary dysfunction, and altered mental status, and it ended up being due to syphilis, meningovascular syphilis. I've been fooled by many cases of, not that many cases, or I would stop getting fooled by it, of atypical presentations of syphilis. So lots of clues we could see in the eyes, but in this particular case, in seriousness, wanting to see if there's a relative afferent pupillary defect that sort of might help us complete this picture of demyelinating disease, although you wouldn't necessarily need that for these conditions. Because we would want to distinguish, is this multiple sclerosis, is this NMO, or is this relatively recently described condition, anti-MOG, which can present with ADEM and also have optic neuritis and myelitis. Okay, Kirtan, what did you find on the examination?
All right. So I will give you some basic labs along with the physical examination in this aliquot. So as for the vital signs, the temperature was normal and the heart rate was fluctuating between 80 120 beats per minute. The blood pressure was normal. The pulse oximetry revealed oxygen saturation to be normal. So SpO2 was normal. The respiratory rate was fine. As for the general examination, as described by her family members, she was not her usual self. And about the neurological examination, the mental status revealed disorientation to time and place. The cranial nerve examination was unrevealing. As for the motor strength, in the lower extremities, it was +3 out of 5 in almost all the muscle groups. And the upper extremities, the power was +4 out of 5 in all the muscle groups. The muscle bulk and tone was normal in all the extremities. The reflexes were normal. As for the plantar reflex, they were downgoing bilaterally. As for the sensory examination, since the patient had altered mental status and was not much compliant. It was extremely difficult, but still we tried our best. So as for the sensory examination, it was negative for a sensory level in the pain and temperature aspect, but it was indeed positive for diffuse hyperesthesia. And the level was not found due to difficulty in testing because of behavioral changes. The cerebellar examination was normal. So there was no evidence of ataxia, dyslidocokinesia, dysmetria, all that kind of stuff. Meningeal signs were absent. There was no evidence of knuckle rigidity. As for the evaluation of higher function, higher function revealed that there was evidence of cognitive impairment with short-term memory losses. As for the psychiatric examination, the psychiatric team suggested that the patient has elevated mood, confusion, disorganized and incoherent speech, delusions, and hallucinations. And as for, I can elaborate a little bit more on hallucinations. So they were mostly visual hallucinations and less of auditory hallucinations. They were most likely visual hallucinations as described by the patient. Aaron, do you want to emphasize on anything else? Do you want to know anything else? And then I can go to basic labs.
No, let's, we can talk quickly about this. I know we're getting to time, but it's a complicated case. I mean, something else has come to my mind to be considered, though I'm not sure how it would fit with the whole picture. But I forget who's up first. We've been going back and forth. We'll just have, in the interest of time, one of you can let us know what jumps out at you on this exam and how it may or may not help. And you can add on the next test you would want to get to try to get us to a diagnosis here.
Yes, I think it was my turn.
Okay.
So, I mean, I think the diffuse strength loss, it is interesting because, of course, this is not in the lower spine as initially thought. And so I think this could be demyelinating, but also what it catches my attention a lot is the fact that she has short-term memory loss and also hyperesthesia. I think that is not something that I was expecting. And the visual hallucinations are also something that kind of makes me think, okay, this could be demyelinating or autoimmune, but it's more localized to maybe the lobes and the brain, because I mean hyperesthesia, I think maybe thalamus, and short-term memory loss, I think temporally lobe, and visual hallucinations and auditory hallucinations, I think occipital and temporal lobe. And so I am really lost. I think I will like imaging of the brain to see what is going on, and yeah, I think that's all I gotta say.
Yeah, I don't think you're lost. I think you're found in many different parts of the brain, localizing these individual functions, isn't it? So let's hold off on the cognitive and psychiatric part. I'm not sure what to do with the rest, right? She has both upper and lower extremity weakness, more severe in the lower extremities. But if this was a very acute myelopathy, she should lose her reflexes. If it's been there for 6 months, she should have hyperreflexia or spasticity or some upgoing toes. I'm not sure what to do with that, and it wasn't part of the history. So is she just sort of asthenic, or is she truly weak? You made a very interesting point about hyperesthesia. There's the Desjardins-Lucy syndrome, which is more popular on the STEP than in real life, but you can have a post-thalamic infarction contralateral pain syndrome. So you lose sensation from your thalamic infarct, then develop this post-infarct pain syndrome months or years later. And she did have that lesion that Kirtan said was thalamocapsular, but why would it be in the whole body? Usually that makes me think more of some type of small fiber neuropathy, where the small fibers are affected. And as a result, your reflexes are normal, your strength is normal, your sensation is either normal or altered with only respect to pain and temperature. And there can be some hyperalgesia, hyperesthesia there, but not sure what to do with that and the rest. If we take all of that out, which we can't do, but I always find a useful exercise in these really complicated cases to take something out and see if you can make a story for the rest of it and see how something else fits back in. It doesn't always work, but if we just thought of this as a 16-year-old woman with progressive changes in her mood and in her cognitive state, and with some autonomic instability here, the heart rate fluctuation. Does that portrait paint anything for you? Take out all of our demyelinating discussion, take out the spinal cord stuff, take out the weakness and all that, just for a moment. And then we'll see if we can put it all together. I'm not sure. But if we had a young woman with this picture of neuropsychiatric changes evolving pretty rapidly and some autonomic instability, does that add up to anything for either of you?
Yeah, I believe that it could either be related to what we thought at first, for example, a CJD, but it doesn't have the dyskinesia picture. But as Valeria mentioned, you could localize this into the limbic region. It could even, if you had like a limbic seizure, I'm not sure if you get visual hallucinations, but I think you do get other types of hallucinations. So if you had something producing an inflammatory lesion there, either from the region, considering something infectious, like that there could be a structural lesion that's swelled, and that could cause the seizures and the progressive changes. So maybe that could make us consider like tuberculomas, for example. But it could also be a viral infection that it's causing an inflammation in the limbic region and producing these kind of symptoms, especially given the time period. So I think I would focus more on there. And I think an MRI would help to differentiate between both of those.
Yeah, great. So one place, Valeria, you mentioned a number of places for these different symptoms, and one sort of system, sometimes instead of thinking of lesion locations, we think of systems, and you pointed out the limbic system, Marco, which is sort of medial temporal, inferior frontal, right? And this is a sort of limbic picture, right? There's memory loss, there's confusion, disorganized thoughts, changes in mood. If this patient was in their 80s and this was evolving over years, right, you would say this sounds like Alzheimer's disease, right? Take out again the spine for now, and because it's the limbic regions, right? Hippocampus, amygdala, perihippocampal regions, etc. So if you frame this as a limbic encephalitis, we would have to think about herpes encephalitis. Does this young woman, has she had in the past some type of demyelinating syndrome, and now, as we said before, maybe that's unrelated, and she just on top of that now has HSV encephalitis. Other limbic encephalitides we have to consider are the autoimmune limbic encephalitis family of diseases. The most famous and probably most common, at least that I've seen, is NMDA receptor encephalitis. So antibodies against the NMDA receptors, glutamate receptors, that present with this syndrome of inflammatory limbic encephalitis. And this was discovered recently, I think in the last 10 to 15 years. And these are usually young women who present with what looks like the onset of schizophrenia. They're often cared for by psychiatrists or sometimes even institutionalized until either they have a seizure or they develop autonomic instability and the psychiatrist realize something isn't right. This doesn't look like schizophrenia, and a neurologist is called, and this is one of the diagnoses we are very glad to make, because schizophrenia can be very hard to treat, right? We don't know what causes it. And this is caused by an antibody. And 50% of those cases, those young women have an ovarian teratoma that has presumably expressed this NMDA receptor and caused an autoimmune reaction and friendly fire against the brain. So the removal of that teratoma, often with steroids, plasma exchange, rituximab, can actually cure these patients entirely. And so it just makes us wonder, as more and more of these antibodies are discovered by Josep Dalmau in Spain and people at the Mayo Clinic, how many patients over the course of history were institutionalized for, quote, psychiatric illnesses that had a treatable antibody-mediated or perineoplastic condition. So is this patient someone with a predisposition to autoimmunity who had ADEM and now has limbic encephalitis? And some of the urinary incontinence and whatnot are just recrudescence in the setting of this new process? Or is this all one process that's something in the family of Nmo, MOG, et cetera? I don't know. So I think we're definitely going to need an MRI and to see if we have white matter lesions and if those fit into a pattern suggestive of a particular condition. Or do we have limbic involvement now, which would make us more concerned about something like limbic encephalitis? I think we lost our whiteboard again. Okay, so I agree we want a brain MRI, and based on that, maybe we may or may not want some spinal fluid or to take another picture of the spine, but tell us what you found, Kirtan.
All right, so I will very quickly give you the few basic labs and the CSF finding, and then I will show you the imaging studies. Is that all right?
Sure. You got the CSF before imaging, or?
Yeah, I have got the CSF findings too. If you
Okay,
want
maybe show us the imaging first before CSF, if that's okay with you.
All right, sure.
So, or the serum labs, anything there to tell us? Probably not, but.
Yeah, no, I can tell you a few things.
Yeah, maybe serum labs
So
and then
the basic
imaging.
metabolic. Yeah, sure. Yeah. So the basic metabolic panel was unrevealing. The thyroid function test, vitamin B12 levels, the HIV, HBsAg, and HCV antibodies were negative. The ANA and ENCA panel was negative. And yeah, now I can show you the imaging.
Yeah, so just so people know while you're pulling that up, I asked for the imaging first because probably that's what would have happened first, just to make sure there's nothing that would make an LP dangerous, and also because we're not sure yet if CSF will be helpful in this case.
Can you see the images?
I can see, if you don't mind enlarging it for us.
Yeah, sure. And I have got 3 sets of images, so I will show them one by one. I apologize for not being extremely pertinent about the images. I mean, they are not very high quality images, but I have tried my best.
They are high quality and fascinating, so go ahead. So we have here coronal images of the brain. These appear to be FLAIR images. And just in the interest of time, we're looking at the patient, so left is right, right is left. There is a hyperintensity in the right thalamic region, extending into the adjacent white matter of the internal capsule. And it looks like there is signal changes in the brainstem and into the cervical cord as well. Anything else that your radiologist saw, Kirtan, that I didn't see?
Sure. Yeah, I can show you the second set of images. Can you see that, Aaron?
Yes. So these are coronal FLAIR images. And first thing that's jumping out to me is that this is a relatively atrophic brain for a 16-year-old. You can see the sulcal spaces are, to me, enlarged compared to what we would expect. And then if you look closely around the lateral ventricles, which are those 2 dark spaces in the middle, there's a lot of periventricular white matter changes that look to me relatively confluent, as opposed to the small sort of spots you might see in MS. And there's a lesion spanning the splenium in the lowest left corner there, the back of the corpus callosum. But so far, we have that thalamic lesion, which is a gray matter structure, but we also have white matter lesions here as well, in a pattern that could be consistent with MS, but other things remain on the differential. Anything else?
Yeah, sure.
And we're looking now at the spinal cord, and looks like a T2 sequence here. So CSF should be bright around the spinal cord, and it does look like there's some patchy signal change predominantly in the cervical cord. The cord looks a little expanded to me, as we're not really seeing the CSF spaces as we should. And I can't really see on here if it extends much beyond the lower cervical. There's some patchy stuff down below as well. Yeah, I see now. Okay. So since I'm just looking at this over Zoom, Kirtan, were there other findings there that you or your radiology colleagues described that you wanted us to be aware of?
Yeah, sure. I can tell you the written description that radiologists gave us.
See if I missed anything.
Yeah, sure.
Sure, go ahead and tell us.
Okay, so do I keep the images on, or should I take them off now?
I think you can take them off, and you can let us know the report, but not the conclusion, just so we make sure we all saw the same things, or if I missed anything just from squinting here on Zoom.
Yeah, sure, definitely. All right. So the imaging studies revealed that There was patchy, irregular, confluent T2 weight flare hyperintensity involving both caudate nuclei, hippocampus, cerebral peduncles, both thalami, both temporal lobes, midbrain, pons, bilateral periventricular white matter, and corpus callosum. Few lesions show patchy restriction of diffusion. No significant enhancement was noted in the post-contrast study. MRI of the spine revealed multifocal, patchy T2 weight steer hyperintensity in the entire spinal cord, extending from the cervical segments to the conus medullaris. Lesions predominantly involved the central cord with mild patchy peripheral involvement. There was no significant enhancement in the post-contrast study. And we even did the magnetic resonance angiography, and it was unrevealing for any regions of dilatation or stenosis in the intracrinial vasculation. And Aaron, if you are all right, I can give you CSF whenever you are ready.
Yeah, I'll just say, so it was a little hard to see. I saw the white matter changes in the thalamus, but multiple sclerosis, as people do more advanced imaging, it's been found that it can affect the cortex, but really shouldn't be affecting the gray matter. So although that's been on our differential, I think this imaging, I should say the deep gray matter, basal ganglia and thalamus, which Kirtan told us the radiologists said were involved. And so if we have symmetric involvement of both white and gray matter, I believe you can see that in neuromyelitis optica, because it doesn't really follow any of the rules of MS. If we had just symmetrical gray matter involvement in a sort of acute presentation with paralysis and altered mental status, I would think about arboviral encephalitides, so mosquito-borne illnesses like West Nile virus, which can cause encephalitis and flaccid paralysis due to poliomyelitis, or affecting the lower motor neurons in the gray matter of the spinal cord. And the arbovirus encephalitides often cause symmetric deep gray matter changes, and probably could cause some white matter changes as well. That wouldn't explain what happened before. And I think one challenge here is we would really need to see her prior imaging and see what's new and what's old, right? Because she had a spinal cord presentation or subcortical spinal cord presentation 6 months ago. If this scan looks exactly the same, right, then we're really thinking this is a new process superimposed, something like Nmda encephalitis, as I mentioned, or an infectious limbic encephalitis. Whereas if some of these lesions are old and some are new, then we might be thinking of the same underlying process, and all that gray matter involvement, I would move away from MS and towards NMO or MOG if we stay in that family. So I think that would be the main thing I would wonder, is if you had access to her prior imaging and what the comparison was. And sometimes you don't, or you can't get it and you don't know. And if there was enhancement, that would tell you there was probably new inflammation, because enhancement shows you the blood-brain barrier is open. And the diffusion restriction, although we think of that with infarction, can be seen in acute demyelinating lesions, infectious lesions, and otherwise. So for me, the most important test would be the prior imaging and the comparison, and the CSF studies to see if there's active inflammation, oligoclonal bands, or infectious signal there, I think will also be helpful. But did you have access to the prior imaging, Kirtan, to compare these two, or it wasn't available when this patient presented to you?
Yeah, so unfortunately, Aaron, I didn't get access to those images. I'm sorry for that.
No, just this is real life, right? Sometimes we can't do that. But I think that would be one of the, whenever a patient has a prior neurologic, now a new neurologic presentation, we want to compare their scans. No need to apologize. This is a reality that some patients change hospitals. We don't have their prior images. Gabby is smiling because we've had this challenge with cases we've discussed before. Okay, so you're sort of stuck. And there was no enhancement, Kirtan? In these images, any enhancement?
Yeah, so so only partial enhancement, otherwise no enhancement as per the radiologist's report.
So there was some enhancement. So some of these findings are acute. Sure. Yeah. So okay. So you got some spinal fluid. Yeah. So I think if all of this is one process, I think we're still in the demyelinating family here, not ruling out a superimposed new process if all of that imaging, and all of those imaging abnormalities are old. Yeah, go ahead.
All right. So as for the CSF examination, the WBC count was 15 cells per millimeter cube, 100% lymphocytes on differential. The protein was elevated at 61.6 milligrams per deciliter. The glucose levels were normal. There was absence of oligochronal bands, and HSV1 and HSV2 PCR was negative. And Aaron, so now the information that I will share, you will reveal the diagnosis. So should I go ahead, or you want to discuss on that CSF?
Yeah. So you have 15 white cells, all lymphocytes, mildly elevated protein of 61, and negative bands in infectious studies. So we have all the information we're going to get from Kirtan here to make a diagnosis. So Valeria, Kirtan, and myself, let's finalize our thoughts here. What do you both think?
I think none of us wants to go first.
Me neither.
So yes, with all of this, yeah, I'm definitely betting on a demyelinating issue. I'm not sure if I'm on MS still. I would go with another one like Nmo or Anti-Nmda, as you mentioned, and then so yeah, that's basically my differential. What we have right now, it's we have these multiple lesions that affect both white and gray matter, and with we don't have a specifically very much inflammatory CSF, but it is inflammatory. So yeah, I guess I would go with a demyelinating disease in all of its spectrum, but I can point my finger more specifically on that.
Yeah, no, I agree with you. That is an inflammatory CSF. We learn in medical school, right? Albuminocytologic dissociation, high protein, low or not very high cells, and that's supposed to be Guillain-Barré. That's a non-specific inflammatory pattern here. So we have cells, but not a ton. We have high protein, but not massively elevated. A viral process could do this, but this syndrome doesn't really fit with a particular viral pattern. So I agree, we're in the inflammatory autoimmune pattern. You maybe like to see some oligoclonal bands to support you there, but they're not always there. We don't have time to get into that area. Okay, Valeria, what are you thinking here? And that gives me one more minute to decide what I'm thinking.
Yes, I agree with Marco. I am thinking more of the immune because of the mild phagocytosis with predomination of lymphocytes and the protein. I was hoping this was post-infectious, so I mean, but it is not. I mean, I don't know, but it doesn't look like. I think, yes, autoimmune. I mean, I really don't know a lot about autoimmune diseases affecting the CNS. I have to read on that, but yeah, that's kind of where I'm putting my coin at. I was hoping actually this was going to be something like viral. You know, Aaron and I have been talking about viruses that can present like difficulty walking and with autonomic dysfunction as well, like HTLV virus. But I mean, the behavioral changes don't match that clinical presentation. I mean, and family history as well would be a good question in that case. So yes, I think autoimmune is probably the etiology, hopefully.
I agree with you. This all looks inflammatory, autoimmune. I don't think we have a signal for infection here. I think our primary question from after the second aliquot or first aliquot, if you don't count the behavioral changes, is what happened originally a demyelinating syndrome? We don't know. We don't have that imaging. And if so, is the new episode another episode of the same underlying demyelinating syndrome? Or is this a patient with an autoimmune predisposition now has a second autoimmune disease? And in this case, if we took out all the spine stuff, right, I would say this, I would be very worried about NMDA receptor encephalitis and wanting the next test actually to be a pelvic ultrasound to look for a teratoma, although only 50% of women with this condition will have it, and men can get this condition as well. So the imaging was very interesting. I would have to look at it in more detail, but the predominant involvement of gray matter is striking. You shouldn't see that in multiple sclerosis. I'm still learning about MOG. It's a relatively newly described phenomenon. I'm not sure if you can get that, but I'm pretty sure optic neuritis is a major feature of that. Although don't quote me on that. I'm still learning about it. And NMO, I think, can do so many different things that I think that is on the table here. But I can't get away from that idea that of NMDA encephalitis, of this sort of very limbic picture that Marco identified, autonomic instability, the very rapid progression in the context of a young woman. And could you get that just from all of those white and gray matter lesions, some new, some old? I guess you could, but I'm not sure. So I know we're supposed to use Occam's razor and make it all fit with one. One of my colleagues likes to say, or it's Hickham's dictum, the patient can have as many diseases as they well pleases to have, right? So there's a limbic picture here superimposed on some recent episode of myelopathy. I'm not sure I can put those two together unless you're fooling me with another atypical presentation of syphilis here, which is always on the differential. So I don't know. I'm going to say my instinct is that this is two different autoimmune processes, a prior episode of ADEM and now NMDA encephalitis. But I'm ready to be surprised. What did you diagnose here, Kirtan?
All right, so let me give you the final labs. So first of all, amazing discussion. All of you are so humble and kind. I mean, you discuss so much and still you are saying that I am going to stump you. I mean, you guys stumped me. I'm not going to stump you. All right, so this is the final record. The CSF testing was positive for aquaporin 4 immunoglobulin antibodies. Testing for anti-MoG antibodies was negative. CSF testing for anti-Nmda encephalitis returned positive, while testing for anti-LGI1, anti-Caspar2, anti-AMPA receptor, and anti-GABA-B were negative. And since the Nmda antibodies returned positive, we did the CT scan of the abdomen and pelvis, as well as the pelvic ultrasound, and it was unrevealing for any malignancy. Yeah, so the final diagnosis was neuromyelitis optica with aquaporin 4 antibodies overlapping with the anti-Nmda encephalitis. And as you mentioned it, the striking autonomic changes as well as the psychiatric changes was actually the key for me too. So that is what led me to suggest to residents that maybe we can look for it. I know it's a rare shot, maybe if they agree. So it was after a long discussions that they convinced the attending to go for it, because the aquaporin 4 was already positive. And then we had to superimpose that NMDR. So they were a bit hesitant, but it all worked well. So thank you for the amazing discussion.
Speaking of humility, Kirtan just slipped in there that he told his residents and attendings to look for anti-Nmda encephalitis, which I love. Tell me, Kirtan, I have not looked into this. You might not have time yet. Have you found in the literature any association of NMO and antibody-mediated encephalitis? I have not. One thing that is interesting that's come out recently is patients who we previously thought had a relapse of HSV encephalitis. Many of those patients actually have NMDA encephalitis. Presumably, I'm saying my own presumption, I'm not sure this has been tested or is presumed by experts in this area, that whatever is happening to the temporal lobe exposes cryptic antigens of the NMDA receptor. The patient develops antibodies and then has sort of a recurrence. So there is that association, but I'm not aware of an NMO NMDA association. Did you find anything on that, Kirtan? I should say one more thing. I keep asking you a question and interrupting you before you can talk. Nmo can co-occur with lupus and with Sjogren syndrome. So if you see a transverse myelitis in lupus or Sjogren syndrome, a lot of those patients actually also have NMO as a sort of separate condition. Interesting association there. NMO and NMDA, Kirtan, I'll stop this time. Any association that you found in the literature?
Yeah, so you are right. So I actually published this case, and by reviewing that, I realized that there have been certain reports of that, but the fact that both of them occurred concurrently at the same time, it is like super rare, like less than 10 cases ever reported in the English literature. But apart from that, the association of anti-MoG antibodies is a little bit stronger than the anti-aquaporin 4 antibodies, but they have certainly been associated, either one followed by the another, but they can also occur simultaneously. Our was a rare case because they occurred simultaneously. But in retrospect, actually, the first episode itself could have been something like that. But at that time, it was presumed to be ADEM. So we are not sure how they may have been concurrent, they may have been separate, but that was how it progressed. And I can also briefly give you the treatment. So she showed the remarkable improvement after being treated with 5 cycles of plasma exchange, pulse IV methylprednisolone therapy. And then she was discharged on prednisone, azathioprine, risperidone, melatonin, with plan to follow up in the 1 month. And on follow-up examinations, she was doing well. She was going back to the school. She was all the things that you look for in a 16-year-old kid. So very amazing.
Amazing. This condition, anti-Nmda receptor encephalitis, is so fascinating. When you see these patients, it's the best described autoimmune limbic encephalitis. And Kirtan, the strength of your presentation and discussion, you have 38 out of 40 people who have stayed a half hour over to hear this case. So I'll keep going. I know people will leave, and it might just be you and me talking, and that's okay too. But it's a fascinating condition. Look at the recent Lancet reviews by Josep Dalmau and his group. It begins often with some subtle memory changes. People think they're stressed, depressed, something sort of very subtle neuropsychiatric changes, progresses to sort of hallucinations, what could look like a presentation of schizophrenia. But the keen psychiatrist, and I have an interesting case that we wrote up, I can send around also, will recognize that the patient is sort of oscillating between withdrawal and agitated psychosis. And usually schizophrenia presentations are a little more monothematic in presentation. They then develop dyskinesias, particularly orofacial dyskinesias, sort of rabbit mouthing type of movements. They can develop chorea and other movement disorders. And if the disease progresses without recognition and treatment, they develop hypoventilation. They need to be intubated. They have seizures. They have autonomic dysfunction, and can go into coma from this condition. And when you treat them, either from removing the teratoma, often concurrently with immunomodulatory therapy, or just immunomodulatory therapy if you don't find the teratoma, they go back through the stages of the illness. They go back through the agitated schizophrenia-like presentation, go back through the memory loss, and come out usually normal, amnestic to the whole episode. It's absolutely fascinating. And to think that the body is producing antibodies against the glutamate receptor and has such a specific presentation, it's an extraordinary syndrome, and not just for our intellectual interest, right? Because these are patients who, without recognizing this, would be institutionalized and often will die without anyone figuring it out. The teratoma story is interesting. You said there was no teratoma, Kirtan. One of my colleagues told me a story that when they were first sort of discovering this disease, they didn't know how often the teratoma was there. With the teratoma association was believed to be stronger. And they saw nothing on the ultrasound, nothing on pelvic MRI, and the woman was doing so poorly even with immunomodulatory therapy. In discussion with the family, they decided to do a bilateral oophorectomy. And the pathologist, I'm sure the story has been dramatized by the people who've told it, in slicing through the ovary pathologically on one slice, on one slide, there were a few cells of teratoma just starting. So some people believe these perineoplastic antibody-mediated syndromes actually lead to a improved outcome for the neoplasm. These aren't cancers, but in cancer-associated syndromes, because the immune system has found the cancer in its surveillance and just tries to attack so fulminantly that there's sort of friendly fire against the body. And the Dalmau group in Spain and Barcelona is publishing new antibodies like every few months. They are so fascinating. There's one that's, I think, like motor hyperexcitability, diarrhea, and cognitive changes, anti-DPPX. There's a newly described one, IGLON-5, with sleep disorders and movement disorders and dementia. I'm probably getting them confused, but in updating my book and trying to get caught up, there's dozens of these. But NMDA is the most common and not to miss, because you can make a huge save, as Kirtan was able to do. And I was going to say, Kirtan, you have to write this case up, but of course you already did. So I hope you can tweet it or send it to us. And yes, someone just put in the chat. Thank you for reminding me. I was going to say, and I got distracted because I think these illnesses are fascinating. A woman who is a journalist developed NMDA encephalitis, was misdiagnosed, was ultimately diagnosed. She wrote a book about her experience called Brain on Fire. And there's a movie about it. I haven't read the book. The movie is okay. I've heard the book is phenomenal. And she actually came out with another book recently about individuals about 50 years ago who pretended to have psychiatric illness to see what would happen to them in the hospital. And she sort of went back and found the professor who sent his students to do this and all the ethics, and her own experience with sort of being diagnosed with a psychiatric illness from a neurologic etiology. Her name is Susanna Callahan, and has written 2 extraordinary books. So if you're still with us at 10:30, we'd love to hear some teaching points from Sukriti. And thank you for all of us who stuck with us. Valeria, Marco, fantastic discussion. Kirtan, brilliant case, brilliantly presented 2 diseases that are very important to recognize in the same case. And wow, amazing that you taught your residents to see through the haze of the prior illness and realize there could be a superimposed illness here. And you gave us enough clues to to see that as well. Great. Okay. For those of you who want to hear some teaching points, please stick around. Sorry, we went so deep into your morning, but this is the most fun I'll have probably all week. So I'll stay as long as we can. Go ahead, Sukriti.
Thanks, Aaron. Thank you, Kirtan, Valeria, Marco. This is really a remarkable case. And I think one of the best parts was how frequently our problem representation was changing parallel to the patient's symptoms. So we began our discussion with the theory of neurological relativity, as Aaron calls it, localization into time course. And we put together a cheat sheet for the time course, essentially. So one way that I remember this now is as 3 plus 2, similar to the chest pain 4 plus 2 that we have on the CP Solver's website. So 3 for hyperacute, 2 for acute, 3 for subacute, and then 2 again for chronic. Just broadly thinking about it, and then toxic and metabolic apply to all time frames. And then the next thing that we did was to localize the behavioral change. And here we basically thought about, was this a primary change in the personality, localizing to the frontal lobe, versus a neuropsychiatric syndrome, either neurological, psychiatric, or etiology, or a systemic illness. And then we layered on this back pain and constipation. And really here we were at odds continuously when thinking about the symptoms, because we were thinking about whether this was a spinal cord disorder, or was this localizing to the brain and the frontal lobe, and whether the loss of sphincter control could explain some of the other symptoms here. And so as we went on to discuss the case, we began to collect clues, and these came in the form of the prior history of ADM. I won't get into the nitty-gritties because we discussed them at length, but something that we learned today is what are the pertinent questions to ask when you have a prior neurological history. The first is, are the background and foreground true, and related? And this is clinically relevant because recrudescence, which is a pre-existing lesion that can decompensate in the presence of systemic illness or medication, could explain the current presentation. And then the second is to revisit how a diagnosis was made in the past, because this could falsely alter how you think about a clinical syndrome. And then we also talked about transverse myelitis and some of the nitty-gritties of how we define it. So we learned that it is a syndrome which affects the full thickness with full thickness axial spinal cord involvement. And remember that not all myelitis is transverse and not all transverse myelitis is autoimmune. We then went on to think about what is longitudinally extensive myelitis, defined as myelitis affecting more than 3 levels of spinal cord segments. We discussed some of the differentials, but thinking fast, Aaron reminded us to think about NMO or Devick's disease first, which is a disease caused by antibodies to the aquaporin 4 receptor. And classically, lesions are found in the area postrema, and they present as refractory hiccups, coughing, and vomiting. When we got some of the information through the physical exam, what was striking was the hyperesthesia, and Valeria really honed on could this be a problem with the thalamus, or was this a small fiber neuropathy? And I think reflexively, all of us, when we think of hyperesthesia, we think of the thalamus, but it's important to also consider a small fiber neuropathy, given that this patient had normal reflexes, normal pain, temperature, sensation. And then finally, when framing the hypothesis, I think this was my favorite clinical reasoning, Paul, is when you have too much of data, it's important to take something out and then see how the rest of it fit in. So when framing our problem representation, we frame this case essentially as a young woman with rapidly evolving neuropsychiatric changes and autonomic dysfunction. And this is classically the illness script of something wrong with the limbic system. We then talked about what could be the limbic limbic encephalitis that could be affecting this woman. And we really honed on NMDA receptor encephalitis, given that there was predominant gray matter change on imaging. We also thought about herpes encephalitis. And finally, with our CSF, layering on our CSF and our imaging findings, we all came to the diagnosis of the neuromyelitis optica with the overlap of anti-Nmda receptor encephalitis. So thank you so much. It was really fun today.
Wow, fantastic synthesis, Sukriti. Again, Kirtan, amazing case for us and amazing. I've been Googling to find your write-up immediately. Valeria and Marco, very complicated case, and you did a wonderful job going back and forth between the big picture and its complexity, but trying to see what patterns we could see and the details and seeing how that could relate. And I think, Sukriti, I'm glad you highlighted this key point. I learned many of our cases are very complicated in neurology, not all, but many, and have complicated past illnesses or other medical illnesses. And sometimes you have this problem representation with 12 things, and it's not step one where you just put them all together and the answer, spits out strep bovis causing, colon cancer, from colon cancer causing endocarditis, and it all fits together, right? Sometimes there's just something that doesn't fit and you take it out and the cloud's clear, right? And here, if you took out all this past history and spine, you say, wait, a young woman, new delusions, hallucinations, possible seizures, this is NMDA encephalitis, right? And I'll have to worry about the rest separately. So that can be a very powerful, I found, strategy and sometimes help you when you may be dealing with two separate things. As Kirtan brilliantly did with his team, right? Telling them, hey, this isn't NMO, right? This thing that's happening now doesn't look like NMO. So thank you to the 23, more than 50% of you who stuck this out for what someone wrote in the chat as I was just looking at, probably the longest VMR of all time. But I hope you still enjoyed it nonetheless. And I think this will be podcast worthy for sure. So thank you all, and look forward to seeing you next Tuesday, and look forward to learning about this NMDA NMO association. Have a wonderful day. Phenomenal job, everyone. Thank you again.